now we're going to move into an area where there's wide consumer interest, and I know several of you have written about this element of cancer, which is the impact of the environmental factors and influences on cancer. Very pleased to have with us to talk about this Heather Young. She is the Associate Professor and Associate Chair of the Department of Epidemiology and Biostatistics at the George Washington University. Her particular areas of research interest are cancer, including reproductive cancers, and the environmental and occupational exposure assessment, so how those exposures affect these kinds of cancers. Also looking at the military and veteran populations, and certainly here in Washington we have a lot of avenues for that kind of research. A couple of things that might be of particular interest in this group. She's very interested in cancer disparities, and I know Candace, you had talked about that and you're here, so I would say if you guys haven't already linked up, you definitely should later, because I think Heather is going to be a great source for the kind of work that you want to do. And she also has published papers looking at ovarian cancer risk in the Central Valley of California. We have a number of California reporters here, including, who's in the Central Valley?
Just jumping up and down.
So that, again, that's a connection you all might want to make later. Heather, thank you so much for being here. We're really looking forward to your presentation.
Okay, great. Okay, so this is just an overview of what we're going to talk about today. It's not going to be real heavy on the science. I'm trying to keep it more applied and practical, but of course if you have more in-depth questions, I'm happy to take those as well. We'll talk a little bit about the environmental and how those relate to internal factors, and a little bit about the interaction between those. Some sources of data, so I'll give you a couple of places to go so that if you're doing your own research, you'll know where to find some things. We'll talk about some specific factors, so this is going to be a real general overview because I'm trying to kind of give you everything in an hour. So it's going to be very general. We'll talk a little bit about exposure assessment, monitoring, and comparison groups, so that if you're evaluating a study or if you're trying to look at some evidence on your own, what are some questions you should ask or things that you can look for. The process of identifying carcinogens and how we go about risk assessment, and then a little bit about occupational studies, and I'll talk about why we're going to focus on occupational studies. And then the big question everybody always wants to talk about is cancer clusters, so we'll touch briefly on some questions you can ask when you're thinking about cancer clusters. So the first thing that when we're talking about the environment, we're really talking about the strictest sense of the definition that we use in epidemiology. It's really everything that's external to the body. And so it can be everything from diet to medications to things that we would more traditionally think about as environmental risk factors like radiation, pollution, but then also pathogens, so infectious risk factors like viruses, bacteria, and some things that you wouldn't traditionally think about. In addition, lifestyle factors such as smoking and alcohol that you wouldn't maybe necessarily put in the category of environmental risk factors, but also when we're thinking about the strict definition fall into that category, and we need to think about how those things interact with what we traditionally think of as environment. When we're thinking about cancers, the estimate from NCI is that about 2/3 of cancers are linked to what they would call an environmental factor. Now that's including diet and lifestyle factors. So obviously that's where we're getting the high number, because we're including things like cigarette smoking in that external environmental factors. Okay, so this is from an older paper, a 1998 paper, but it really hasn't changed that much. This is looking at avoidable environmental factors, so proportion of cancer deaths, which are linked to avoidable environmental risk factors. And we can see that the highest percentage is linked to tobacco. And the reason you're seeing such wide ranges here is that this data was taken from a number of studies in the area. And so recently what we would see is that the numbers from tobacco have been coming down as tobacco prevention programs have been working. Numbers from other sources like diet may be coming up more as we learn more about the influence of diet on cancer, and also exposures within a diet, so things like pesticides and those things that people could be exposed to within their diet. But what we can see on one of the points on this slide is that some of the things that we might think of as traditionally environmental, so pollution of air, water, and food, really the proportion of cancer deaths linked to those is relatively low based on what we know from epidemiologic research.
Can I make one comment?
Yes.
Everybody, we will be posting these slides on our website afterwards, so you don't have to take pictures, but you will have them.
Yes, and I'm speaking very rapidly, but a lot of what I'm talking about, I've also included in the notes section of the slide, so I think that should show up for you too. So if you don't get everything that I'm saying, and I've tried to include some sources for journal articles where I've included numbers so that you've got as much information as you need. But if you find something in there that I didn't source, feel free to send me an email and ask me or contact me. I'm happy to dig up the source if I missed it on the slide. So when we're talking about internal factors, the ones that we really have to think about are genetics and family history, and then how those interact, so gene-environment interactions, and then immunity and hormone levels, so how people's immune systems play into how they're able to interact with external environmental factors, and then lastly, susceptibility and detoxification. And that's really a big one when we're talking about environmental factors. Oftentimes when we're talking about chemicals that are carcinogenic, when they enter the body, they may not necessarily be carcinogenic, but their metabolites are what's carcinogenic. So, for example, if someone eats a fruit that has a particular pesticide on it, that pesticide in its raw form may not be a carcinogen, but when the person metabolizes it, that metabolite then becomes carcinogenic. Where genetics come into play is that people are programmed to either be fast or slow metabolizers of various substances. So if someone's a fast metabolizer, that can be a bad thing if the metabolite is carcinogenic, because now they're metabolizing the chemical that came into the body, turning it quickly into a carcinogen, whereas maybe if they were a slow metabolizer, this chemical would have passed out of their body before it was turned into a carcinogen. In the other way, being a fast metabolizer can also be a good thing, so that if the chemical that you're taking in is a carcinogen, but it's metabolite, so it can be detoxified by metabolism, if you happen to be a fast metabolizer, then it can work the other way. And so it gets very complicated when you're thinking about what someone's taking in. Is it what they're taking in, or is it the metabolite of what's coming into their body, and then how fast or slow is that person processing it? So the key here is that it becomes very difficult to apply findings to large segments of the population because we have that gene-environment interaction going on. Okay, so these are some examples of sources of data on environmental agents. The two big places where you'll find data are IARC, and I've given you the web link. They have a comprehensive program that evaluates carcinogenicity of chemical and physical agents. And what they do is they meet annually. They look at all of the available evidence. They pick chemicals that they'll do reviews or re-reviews on. So some of them may be new, some of them may be old chemicals where there's new evidence. They'll look at epi evidence, toxicology, animal studies, and any sort of genetic evidence that they have available, and then they'll update these lists to let you know the level of carcinogenicity for various agents. NIOSH and the National Toxicology Program have a similar scheme. They publish a new list every 2 years, but they don't cover nearly as many agents as IARC does. But those are two sources where you can find information about whether or not a particular agent has been determined to be a carcinogen or not. And these lists aren't just limited to chemical agents. They do also cover some pathogens. They cover physical agents, so things like radiation will also land on the list. So this is an example of what you would find from IARC. This really summarizes the different categories that IARC comes up with. And so when IARC categorizes, they give their carcinogens a group. It can range from group 1 to group 4. Group 1 is where they've determined that something's definitely carcinogenic to humans. Group 4 is where they say it's probably not carcinogenic to humans. Now, what you'll see here is if you look in Group 1, we only have one thing that falls in that category. That's because what they're trying, it's really difficult to prove the negative. And so most things that end up will fall in the not classifiable as to carcinogenicity, meaning that they just don't have any evidence one way or the other. It hasn't shown up as a carcinogen, but they don't really have anything that's proven that it's absolutely not a carcinogen. So they fall in that category. The place where it gets really squishy and difficult are those groups 2A and group 2B, because there's evidence, but the evidence isn't strong. And so you have to have really, really strong evidence to move things into this group 1. So things that are in group 1 would be things like radiation, cigarette smoking. So those things where we definitely know that it's a established carcinogen, as opposed to things like then group 2A and 2B might be things like a particular pesticide where there's been some studies that linked it to particular cancers, but it's not necessarily clear. There's not a large body of evidence looking at those things. And this is also not a comprehensive list, so things are always being added to the list. So if it's not on the list, it probably just means that it hasn't been studied or they haven't evaluated it yet. So we're going to do one quick slide on pathogens, and you can do an entire course on infectious agents and cancer because more and more is coming out about infectious agents and cancer. But to briefly touch on the ones that you should be aware of are HPV, and so those have been linked to obviously cervical cancer and then also head and neck cancers as well. There's more evidence coming out linking it to some oral cancers. Hep B and Hep C being linked to liver cancers. Epstein-Barr virus has a particular link with lymphomas. And then lastly, HHV8 particularly is linked in immunocompromised populations to Kaposi sarcoma. So we're thinking about issues with populations with HIV and AIDS. When we're talking about bacteria, the one where we see a major link is H. pylori, and that's with stomach cancer. And so that's the one that you should be aware of. And then lastly, aflatoxins. We don't hear a lot about aflatoxins, but they are linked with liver cancer. And essentially, we don't hear a lot about them is because they're a contaminant in the food supply. And so usually we're not going to see those. But they can be linked to liver cancer if there are contaminated food supplies. Okay, so one of the major agents that we do know is carcinogenic and everyone worries about in the environment quite a bit is radiation. So the obvious one is the UV radiation that all of us are exposed to with skin cancer. And that's, a lot of people don't really think about that too much, but that's the biggest source of cancer risk when we're talking about radiation. What people most traditionally think about is ionizing radiation. And so when we're thinking about ionizing radiation, one of the common things you would think about would be nuclear materials. So things like looking at links with Hiroshima and Nagasaki, Chernobyl, the nuclear plant in Japan. So looking at all of those risks, those are some of the things that would be making headlines that people would be looking towards, but are not necessarily very common. The one nice thing about those is that they're very easy to study and to follow because we know that there has been an exposure. So there's an event that we can track and start tracking people's exposure from that event and then follow them forward. So it's very easy to kind of get your cohort and follow those people. Radon exposure in the home. So there's actually been quite a bit of press about radon exposure in the home. People tend to get very excited about, having their home tested for radon gas exposure. It really only counts for a modest increase, about a 5% increase in risk in lung cancer. And so although radon exposure in homes does account for an increase, it's not a huge increase. And a lot of it is difficult to disentangle because it's often confounded by smoking exposures in the home as well. And we'll see an interaction with people who are smokers also having increased risk of cancer from radon exposures. Lastly, therapeutic and diagnostic radiation is the other category of ionizing radiation that we would think about. For everything we've heard about, going through the X-ray machines at the airport or numbers of diagnostic X-rays, although you do want to be careful about it, diagnostic X-rays really haven't been linked definitively with any cancer risk except in women who are pregnant, and we have a definitive risk of diagnostic X-rays in leukemia, subsequent leukemia in their children. And then therapeutic radiation is used often or was used more frequently in the past, and that's been linked definitively to thyroid cancer. But for the most part, it doesn't cause cancer, but there aren't a lot of definitive studies that will link any sorts of diagnostic X-rays with cancer risks.
Aren't there studies that link therapeutic radiation with secondary cancers?
Yes. So some of the treatments, and that's some of the newer studies now that we have cancer survivors that are living much longer. And we're now seeing increases, particularly in children who had cancer, who had radiation as a treatment for their first cancer, now seeing increases in second primary cancers as they move into adulthood. So that's one of the newer areas of research where we are seeing some more of the therapeutic radiation being linked. Medications and hormones, another external factor that we don't necessarily think about as environmental, but does fall under that category. And so in that same vein, thinking about chemotherapeutic and immunosuppressive agents, again, a lot of studies looking at cancer survivors who were treated, particularly children, and we're now seeing them pop up with second primary cancers. Particularly chemotherapy has been linked in a few studies with increased risk of lymphomas later in life. So that's one area of note. Hormone replacement therapy has obviously been linked in the past to breast and endometrial cancer, and so that's why a lot of that recommendation was changed, and also formulations were changed quite a bit once that link was made. Oral contraceptives. So they're a very interesting story because oral contraceptives are really definitively linked as a big protective factor for ovarian cancer. But some of the formulations can also be associated with early onset breast cancer. And so that sometimes causes a lot of difficulty with recommendations with health professionals. A lot of the studies have found that the estrogen progestin formulations are the ones that are being linked with the early onset breast cancer. So some physicians will advise, if you have a family history or have a possible risk for breast cancer, to not use those particular formulations of oral contraceptive use. And then previously, when estrogen-only preparations of oral contraceptive use were being recommended, those also were found to increase the risk of endometrial cancer. And so it gets very complex because we have the ability to really decrease the risk of ovarian cancer, but we have to weigh that with the risk of increasing other types of reproductive cancers. And then obviously, the historical story with the DES, the diethylstilbestrol, was given to pregnant women to decrease symptoms of morning sickness, but was later found to be linked to vaginal cancers in the female offspring of those women. And now some studies are also showing, since those women are aging, that it may also be linked to breast cancer in those female offspring. And so this was one of the first sort of seminal studies where we were able to see something that was therapeutic for the mother but had a carcinogenic effect on the fetus. Okay, So shifting more to what we traditionally think of now as our environmental exposures, one of the big categories are what people are exposed to on their jobs. And one of the reasons that environmental epidemiologists will really focus on occupational populations is because they're captive. And we can measure a lot of times exactly what they're exposed to, as opposed to when someone's just out living and they're in the environment. It's really difficult to figure out what they're being exposed to in their home or as they're out. Whereas in the job, we oftentimes know exactly what they're exposed to and what types of job titles they have, and so we can measure their exposures much more easily. And so you'll see that a lot more is known about occupational exposures than general environmental exposures. And if we know something about an environmental exposure, it likely came because it was at one time an occupational exposure that we were concerned about. So some of the important solvents, particularly that are known carcinogens, things like benzene and carbon tetrachloride, often those are solvents that had been used in the past, and the use has declined quite a bit in dry cleaning and restoration and of furniture and paint occupations. These are particularly associated with leukemia. Asbestos is one of the major fibers that we would be interested in, but also silica and dust. Asbestos is interesting because it's definitively linked to mesothelioma, and it's estimated that about 70% of mesotheliomas are due to occupational asbestos exposure. And so it's a cancer that we really see that's highly linked specifically to asbestos exposure. The other thing about asbestos exposure is that it has extremely synergistic effects with cigarette smoking, and so we find people that are smokers, the risk for lung cancer and mesothelioma when they're exposed occupationally to asbestos will skyrocket, going up sometimes anywhere between 5 and 20 times higher than if they were non-smokers. And so it's one of those areas where, again, you're looking sort of at interactions between exposures can cause effects that are much larger than what you would see looking just at one single exposure. Vinyl chloride, chemical primarily used in manufacture of plastics, is linked to liver angiosarcomas. It's a very rare type of cancer, and again, trying to decrease the exposure to that particular chemical now occupationally, since this link was definitively established. When we're thinking about dioxins in an occupational setting, most of the exposures are going to come from paper bleaching or wood pulp processing, so that's where most of the environmental exposures come from. A lot of dioxin exposures are linked to reproductive cancer, so any cancers that are might have a hormonal association are found to be exacerbated by exposure to dioxin. So again, looking at interactions between the internal hormonal environment and also what you may be exposed to occupationally. PAHs, mostly produced by wood smoke and diesel exhaust. These are primarily going to be linked to bladder cancer. Definitively, there's been some talk about some other cancers, lung cancer, that type of thing, but really the only strong link at this point where we have good, strong epi-evidence is with bladder cancer. And then the last piece, and this is kind of really old, but you're really only seeing the cancers now, is the use of aniline dyes in leather industries and in dye production because it's linked with bladder cancer. And bladder cancer has a really long latency period, meaning that it takes a long time to develop. And so what we're just starting to see now is people who worked with these particular dyes in leather and dye production, now 40 years later, developing this bladder cancer. And so a recognition now that these were not good exposures and that they needed to be removed from the industrial process. Yes?
Which of the solvents did you see was associated with dry cleaning?
Mostly carbon tetrachloride and chloroform was what they used in the dry cleaning industries, and a lot of dry cleaners are, again, moving away from that because of the definitive links now.
Yeah, we had a recent issue with a dry cleaner basically contaminating groundwater. A lot of people were on well water in that area.
Yeah, so there's, and there's actually a big, since I work with military populations, there was a large concern at Camp Lejeune. There was a water contamination, and it was originally thought that some of it was due to some of the training activities that were going on, but then they also found out that there was a dry cleaner off base that was dumping things that were going into the water table, and so there are a couple of clusters that are being investigated, a cancer cluster and also a birth defects cluster that were linked to water contamination. So. Okay, so apologies for a very busy slide, but this is sort of looking at additional occupational chemicals. When you look at those lists of what we know definitively cause cancer, a lot of them on the list are what we think of as heavy metals. And so this is sort of just giving you the heavy metals, the cancers that they've definitively been linked with, and the industries that they're present in. So we can see everything from arsenic to nickel. The only one on this list that isn't definitively linked and only isn't a definite carcinogen is lead, and its lead falls into the probable carcinogen category just because we don't have enough evidence at this point to move it into the definitive category. Okay, so when we're looking at the list of environmental chemicals, now we'll see that a lot of the same things that we saw on the occupational list are now showing up on the environmental list. And that's because, like I said before, it's much easier to see the effects in an occupational setting where you have much more concentrated exposures and a much more captive population. Once you see the effects in an occupational setting, then people start to become interested in, well, what does it look like in an environmental setting? One of the concerns was benzene in regular gasoline fuel. And so how does this, because we know that benzene is a known human carcinogen, then how does this relate when people are fueling their cars and that sort of thing into regular exposures, not occupational exposures? Right now, the link is really tenuous. The exposures aren't really high enough that we're seeing any definitive environmental links. You have to be exposed to pretty high concentrations of benzene, so something you would see in an occupational setting. Fibers and dust. So again, a lot of talk about asbestos, but when we're talking about in an environmental setting, there's actually relatively little evidence that cancer risk increases when people are exposed environmentally to asbestos. So an example would be if you're in an office building that had asbestos in it, but it's not, it's contained, it's not being, no one's doing work and pulling down ceiling tiles and that kind of thing, your cancer risk is relatively low. It actually increases when they start doing all of the abatement work that's supposed to be good for you, because then they've got the fibers all over the building, and then we have the occupational issues. And so now they're sort of rethinking some of these issues with the older buildings and the asbestos, and since there's relatively little evidence that environmental asbestos exposure is linked to increased cancer risk, that it may be better to leave some of it than to go through all of the abatement activities and be pulling all of the fibers down into the air. The dioxins again. So dioxins are really pervasive in the environment. They're going to come from pesticide exposures. They're going to come from incineration. And the problem with dioxins is that they're also bioaccumulate. So they're fat soluble and they're going to accumulate in people's bodies. But there's also not strong evidence linking them at the levels you would see in the environment with cancers, particularly reproductive cancers. I think, and this is just my supposition here, that we may start to see some things as we have populations who have been exposed to dioxin for much longer periods of time, starting to age and come into the age where we would see increased breast cancers, increased ovarian cancers, increased prostate cancers, where having environmental exposure to dioxins that's bioaccumulating for long periods of time will start to come into play. And so I think on this one, the evidence is really still out. I don't think we can say that there's a low risk for environmental exposure to dioxin. I think we're in a sort of let's wait and see what it looks like for environmental environmental exposure. In terms of environmental exposure to PAHs, these are mostly going to be found if you heavily grill your foods. And so there are a lot of dietary studies with the way meats are grilled, and they can generate PAHs, and looking at risks of colorectal cancer being increased with people who eat lots of heavily grilled meats. Again, these risks are still pretty weak, though, compared to what we're seeing on an occupational scale. And so right now, there are small risks associated with PAHs that you would get from dietary exposure, but they're not on the level of what you would get if you were occupationally exposed to levels of PAHs.
Excuse me, Heather?
Yes.
Are the PAHs also produced when you grill vegetables, or is it something about meat?
It's something about the meat. It's generally the fats in the meat that are producing the PAHs, and that so when they're grilled, there's certain levels of grilling. We actually had a scientist come in from NCI, and one of her jobs is she grills meat in a variety of different ways. And she measures the amount of, with the level of char and how it's been grilled and at what temperature it's been grilled, and what's the optimal way to cook the meat to reduce the amount of PAHs. Because a lot of the dietary advice we get, grill your meats. That's a healthy way to cook your meats. But, if you're not doing it the right way, then you're generating a lot of carcinogens in the way of PAHs. And so what's the best way to do that?
So is there a right way?
There are ways that'll do it. So far, what she seemed to have found is that not a heavy char. So you don't want to have a lot of blackened product on your meat. The PAHs are going to increase in meats that are higher in fat, and so leaner cuts are going to be better. Lower temperatures of grilling as opposed to very high temperatures, those types of things.
Did gas or charcoal matter?
She didn't think that gas or charcoal seemed to matter that much so far in what she had been looking at. Pork products, foods that had that were preserved, so things like hot dogs, sausages that had also were particularly bad because, again, we've got other chemicals that were used in the preservation, and then we're grilling them and getting all sorts of interactions. Again, though, nothing that I would stress out over unless you're eating high volumes of grilled meat. So the next two are arsenic and the chlorine byproducts. These are actually two that have pretty strong definitive links with contamination in groundwater. There have been several studies, particularly in the Midwest, where they have issues with groundwater contamination with arsenic, that have looked at and found strong evidence for increased risk of bladder cancers, skin cancers, and lung cancers, interestingly, that are associated with arsenic-contaminated drinking water. And then also chlorine byproducts in drinking water and increased risk, about a 20% increased risk of bladder cancer. And so when we're really looking at environmental risks, the arsenic and the chlorine byproducts are probably two of our strongest. And again, if you think about it, that's kind of relating back to you're getting relatively high concentrations because it's people's drinking water source, and it's also the source of water that they're using for cooking, the source of water that they're using for bathing, and so much higher exposures than you would get if it was just something in the ambient environment that you weren't exposed to every single day. And then lastly, air pollution. Air pollution, yeah, sorry, Linda, go ahead.
About a year ago, there was a lot of press around arsenic in rice because it's such a water-intensive crop. Was that overblown or something we should really worry about?
I don't think there's enough studies, but I think it is something that you really should be concerned about, again, because arsenic is a known carcinogen. It's not something where we're saying, oh, maybe, maybe not. There are definitive studies that say arsenic is a carcinogen. There are definitive studies that link consumption of drinking water with arsenic to cancers. And so I think it really is something to be concerned about not enough studies to know what the concentrations in the rice would be and how much rice you would really need to be consuming. But I think it is something that was a cause of concern just because of what we know about arsenic as a carcinogen. Okay, and then lastly, air pollution. So air pollution is actually one of the most studied environmental risk factors when we're talking about cancer. A lot of studies you will find will say increase in lung cancer of about 1.5 to 2 times with people who are exposed to air pollution. The problem is what is air pollution? The exposure is really not well defined, and what parts of the air pollution. So it's the reason it's been the most studied is because the exposure itself is so poorly defined. So what chemicals are we looking at in the air? Are there particular things in the air that we're interested in? Are there certain amounts of levels that you need to be exposed to? And so it's really difficult to define that exposure, and so that's why there have been so many studies, but there does appear to be an increased risk sort of to the general term.
I thought air pollution was mostly volatile organic compounds. Are there other chemicals that you're looking at as well?
Yeah, there are other chemicals like particulate matters, so those kinds of things. When we're looking at areas with high smog, so if you want to think about things you would see out in the West Coast, like in Los Angeles, where you have a lot of particulate matter, carbon monoxide would be another one that really hasn't been linked as a carcinogen, but it's a component of air pollution that, really hasn't been studied. And so, all of those things, it's such a, that term air pollution is so amorphous that it's really difficult to figure out what exact part of that is increasing the cancer risk.
I was wondering, what about things like feedlots or oil and gas, areas? I mean, do those have any significant air pollution? I mean, obviously, they smell terrible, but I didn't know if there's anything in particular that stands out to you for those.
I don't know much about the feedlots. I don't think I've seen a lot with that. Oil and gas, some of the studies are new, and they're going to be coming out of the activities in the Gulf War. So when they burned the oil wells and a lot of that, and so a lot of that's going to be kind of following the veterans populations, because we've seen numerous complaints of people having respiratory type illnesses and fatigue-like illnesses that have been exposed to high levels of the pollution from the burning of the oil wells, and so following those populations along. And there's also a large body of research, and I'm not all that familiar with it, with the 9/11 rescue workers too, and the amounts of contaminants in the air that they were exposed to as well. And so again, I think you're not going to see, because again, lung cancer tends to be something with a really long latency period. I think we won't see that story play out for at least 20 more years. But we're seeing sort of the beginnings of it with looking at respiratory illnesses. Okay, so when we're thinking about, yes?
You mentioned it, but we get a lot of questions about this. What about things like Wi-Fi and cell phones, which a lot of our readers are convinced are cancer-causing?
Yeah, so there's really no evidence. And that doesn't mean, and so I think that where IARC puts it is IARC puts it in that not classified category, because there's just no strong evidence one way or the other. Some of it is because the technology is so new. So again, things like the cell phones or the Wi-Fi use, it just hasn't been around long enough to see it play out. If there was an increased cancer risk, and I know a lot of people are concerned about, wearing the Bluetooth around. If you have that Bluetooth in your ear, you're going to end up with brain cancer because you've got all, who knows what waves. And, it just, people haven't been using it long enough, I think, to really see. Now, there are some animal studies that will, that show some increased risk. But again, there are also animal studies that show that there's no risk. And so it's just really difficult. The other thing that I didn't mention, again, is because there's no real evidence, are the power lines. I know in my neighborhood, for instance, they're wanting to put some of those power lines through, and one of the things that the neighborhood association started to talk about was, oh, but there's a huge cancer risk, and we know there's a huge cancer risk, and then I had to be the bad guy and say, well, we don't really know that I mean, they're ugly and I don't want them in my neighborhood, but we can't use that there's a huge cancer risk because there aren't really any studies that point to that definitively.
So with the cell phones and with the power lines, is it just a matter of these cancers having such a long lead time that we wouldn't be able to see the case clusters pop up for 20 years? I mean, what's the lead time on things like this?
Yeah, so brain cancer is somewhere around 8 to 10 years where you would see.
Start seeing, I mean, we've been using cell phones.
Yeah, so you should be able to see things start to pop up with cell phones, and so I think there probably are studies kind of ongoing now that are going to start to really look at that.
I mean, this is observational, in other words.
Right, these are really going to be observational, and it's just going to unfortunately take us having to follow populations to see, oh, okay, we all shouldn't have been wearing those, Bluetooth headsets around for the past 10 years, because now we're seeing a real increase in brain cancer rates, or, head and neck cancers, for example.
So what's going on there? I mean, we've been using cell phones for what, 20 years?
Yeah.
So 10 years ago, we should have started doing observational studies for the first 10 years.
I mean,
we ought to know, right? What's going on?
There are a lot of that have been animal, and right now there's no real evidence. There are some studies out there looking at some cellular technologies, some of the older types, and no real evidence was found. A lot of animal studies where they kind of implant some of the technology in a little mouse's brain and let them run around for a while, and they haven't really found anything with that either. So at this point, I would say there's no good evidence, and so that's why it's kind of falling into that not classifiable. They don't want to say no because we haven't followed everything through. And technology keeps changing, so some of the new stuff we're doing may turn out to be not that great. But right now, there's no solid evidence.
Question going back to the air pollution.
Mm-hmm.
So if there's no definitive answer of what exactly is air pollution, then what is that we're looking for when it comes to communities that are located near places where they do a lot of trash and waste management? Why is there I hear a lot of increases in kids with asthma and things of that nature. So what is it in the environment that is causing these kinds?
Well, those are probably linked to particulates. And so if there's a lot of waste incineration, I would be particularly concerned about the particulate matter that's coming from the waste incineration. I mean, the other thing you'd want to be concerned about if there was any cancer would be dioxins, because dioxins are a byproduct of waste incineration often. And so then you may start to see increases in reproductive cancers in communities that are located where they would have heavy exposure from those byproducts. Okay, so when we're talking about exposure assessment issues, it gets really tricky. One, because our populations are transient. So when we're thinking about an exposure that someone had, and then a cancer that we want to look at, that best case scenario is probably 8 to 10 years down the road, worst case scenario maybe 40 years down the road. And then we need to go back and backtrack their exposure to what they may have been exposed to previously. It's going to be really difficult to recreate those exposure profiles, particularly when we're speaking about environmental exposures. So we're thinking about, where did someone live 20 years ago? What might they have been exposed to? Do we have any sort of environmental data that will tell us what they were exposed to? A lot of what we do have in environmental data is ecological, meaning it applies to the entire area. So if we have air pollution monitoring data, even if we have air pollution monitoring data for 20 years, it just tells us what was happening in that particular area, but it doesn't tell us, well, was the person outside on that day? Were they actually exposed? There's no real specificity to the person. So that becomes difficult. Again, mixtures of agents, so any kind of synergistic effects. So if they had exposure in their food, but they also had exposure in their water, if they were smoking, if they used alcohol, if they had some sort of medications that they used, gene-environment interactions, all of those need to be taken into effect. The other thing we don't know about a lot of these agents is what the dose response looks like. So is it linear? So when you get to a certain point, then your cancer risk, it increases along a straight line. Do we have to hit a certain threshold? So a little bit of exposure is okay, but when you get above that threshold, that's when you're going to start to see increases in cancer risks. Can we get to a certain point where we're not going to see any increases in cancer risk? So, if we're in this area, then it's going to start to level off. So it's not a linear association, but we'll see it level off at some point. Chronic versus acute exposures. So if someone has a very short term but high exposure to something, is that equivalent to someone who has a long-term exposure in very low levels? And we don't know that about a lot of the environmental exposures. One of the examples I like to use, because it's kind of easy to wrap your head around, is one of the ways to measure cigarette smoking is what we call pack years. And so someone who smokes 1 pack a year for 40 years, they get assigned to 40 pack years. We could also have the same person smoke 40 packs for 1 year. Those are very different types of exposures, but they're getting the same metric. And so when we're using those environmental exposure metrics, we really have to think about what are they measuring, and were these chronic or acute exposures, and do they get lumped together when we're looking at the metrics?
Can I just say
Yep.
before we move on,
Mm-hmm.
that previous slide is one of the most important slides for journalists. At some point in your career, you're young, you're going to get the call from somebody in the community who says, 5 kids in my neighborhood have gotten cancer in the last 10 years. It's clearly because of X thing happening in the environment. And maybe it is, but that slide that Heather has just described is the reason that maybe it isn't, and that it's incredibly complicated, and that you cannot rush to print and say, it would be very easy to write the he said, she said story, right? Community activists say 5 cases, and you start with an anecdotal lead, and it's very compelling, and public health officials in the area say, we don't have enough evidence, we can't, these are very complicated things, and it's just really important to be aware of all of those factors when you're reporting on any kind of environmental health impact.
Yep.
So what's your kind of best practices for journalists when faced with that exact situation? What should we be doing?
So hold on for a minute, because when we get about 3 more slides in, I have a slide that gives you questions to ask if someone calls you about a cancer cluster.
Didn't mean to get ahead of that.
That's okay, but that's an excellent point. So when we're talking about monitoring, there are 2 types of monitoring that we generally use. Environmental monitoring, so that's like, we'll stick something outside and we'll get, we'll monitor the water supply, that kind of thing. Obviously that's non-specific, but it's less expensive, and sometimes it's the only thing we have available. The other part is biomonitoring, and so this is when we can draw someone's blood and find out exactly what they're exposed to. We can take a sample of someone's hair. We can take a urine sample. The problem with those is that they all have very different measures of what we're looking at. So if we're using someone's blood, has to be something that they've been exposed to for quite a bit. It's circulating in the body. Urine, it's something that they're excreting, probably going to be a non-persistent exposure that we're seeing, and so there's a lot of timing issues. But the nice thing about biomonitoring is that we know that the person had that exposure, so we can link it to an individual. The other thing you want to think about when you're evaluating any sort of evidence, so if you're looking at a scientific study, is what are the comparison groups they're using. Best case scenarios, you want to get an unexposed group. The problem is that when you're looking at an environmental study, it's often difficult to get an unexposed group because you're in a particular setting. All right, well, who wasn't exposed? In occupational settings, it's a bit easier to get that because you can find people who worked in the particular job and people who didn't work in the particular job. You can also use other types of comparison groups. And so a good example is if you were doing a study looking at exposures to firefighters. Well, who would you use as a comparison group for firefighters? You don't want to use the general population because firefighters are much healthier than the general population, and so it's not a good comparison group. So oftentimes they'll use some other active working population, police officers. military veterans, people who might not have the same type. Oh, you're laughing.
About police officers, it's just based on stereotyping. I'm sorry.
That's often what they use. They try to find another sort of active work population that would not have any of those same exposures. And so, but then you have to think about, well, how comparable are those groups? Are they comparable in terms of other characteristics? And so that's one of the things you kind of want to evaluate when you're looking at a study. Did they use a comparison group that really was a good comparison group? Okay, I won't spend too much time on this, but when we're identifying carcinogens, the main way it's done are laboratory experiments, so essentially looking at cell lines. Does this turn a particular cell? Does it mutate a particular cell? Animal studies. And then lastly, the human studies. And so most of these are observational is the data that we're left with. The ecologic studies are going to be things where we're going to see like, oh, these regions of the country had really high exposure to air pollution and we see high rates of lung cancer. Very non-specific, so looking on a regional level. Case control studies are the second level of evidence, so that's where we'll look at cancer cases, pick community controls or some other type of control, and we'll ask people to go back and recall what their exposures may have been, or we'll go back and look for data. So again, obviously there are problems with that because we're asking people to go back and reconstruct exposure data. The best type of epi study or observational study that you'll see are the cohort studies, because they'll start with a population and they will follow that population through through a lifetime. So a good example is what they're doing with the 9/11 workers. They had their exposure, now they're following them forward, and we're able to capture all of the different health events as we're following them forward. We're not trying to go back and reconstruct things. So obviously you would put more weight on those cohort studies. Unfortunately, there aren't tons of cohort studies because they're really expensive and it's really difficult to follow large numbers of people for long periods of time, particularly if you're looking for very rare events. And some cancers that you're going to find pop up are very rare, so you need extremely large cohorts to see those cancers even pop up in your particular studies. So again, if we're following a cohort of people and we don't see any cancers pop up, it may just be because the cancer is so rare that our cohort isn't large enough to see any significant effect showing up. And when we're talking about risk assessment, 3 questions we want to think about. Potency. So how likely is our agent to increase the cancer risk? So thinking about things like what was the relative risk. Exposure type, so high versus low levels, chronic versus acute. And then is there a dose response association, and thinking about threshold levels. We're thinking about occupational studies. I already mentioned that the reason we use a lot of evidence from those is because they're better defined. They're better measured, and we usually have higher levels of exposure. And following the populations in an occupational cohort is much easier. People tend to stay in their jobs, or they're part of a union, particularly if we have union types, then we can follow them based on their records. The problem with occupational studies is a lot of those studies lack women, and they lack minority coverage. Also, if we're thinking about things that may be related to undocumented workers, so pesticide exposures, it's very difficult to track any of those exposures. Okay, I'm going to skip this slide in the interest of time because I know you all want to get to this slide. Okay. Yes, those are posted, so yeah.
So you can go back and look at the ones that she skipped.
And if we have time after I go through this slide, I'll go back to that one. But I want to make sure that I get through this one because I think this one's an important one. So this is the slide on cancer clusters. And this is sort of what everyone should think about when you get a call about that there may be a potential cancer cluster. These are the questions that a public health worker is going to go through. So this will also help you understand if the Department of Public Health comes back and says, you know, we don't really see anything. This is what they've gone through. This is the list of evidence that they've worked through. So what is a cluster? A cluster is strictly defined if we see a high concentration of cases in a defined time period, a defined geographical setting, or a defined group of people. Okay, notice here that it needs some sort of definition. We don't want it to be like, oh, in this entire town or over a 50-year period or something. There needs to be some sort of definition, so way we can circumscribe this cluster. The very first question that we ask, and it's near the bottom of the list, and I probably should move it up, is we ask, are the observed number of cases really higher than what we would expect by chance? So we may look at, and someone in the neighborhood may be really alarmed because we had 5 kids in this neighborhood who had leukemia. But is that number really statistically higher than what we would expect in a population of children of that size by chance? Sometimes it just seems really high because you know everybody in the neighborhood, and sometimes it really is statistically higher. And so that's really the first question that the public health department is going to look at, is do we have a statistically higher number than what we would expect in this group by chance? The second thing we're going to look at is that the cases have some sort of related etiology, or are they just due to chance? So this is thinking about, are they a specific type of cancer? So if we're saying, oh, well, I know 10 people in my area that have cancer, but we have 1 brain cancer, 3 breast cancers, a prostate cancer, and a leukemia. Okay. Again, may sound alarming, but we're all over the place. They're not really linked by etiology. And so we want to be looking at things that have similar causes that are etiologically linked. It becomes really difficult. I'm sorry, go ahead.
Couldn't you have a cancer cluster that is general cancers or a variety of cancers?
It's really, really, really uncommon for something to be such a broad-based carcinogen that there's not going to be some specificity.
So I don't remember, like at those Superfund toxicity sites, what kind of cancers, what did we see there with cancers?
So usually, it depends on what the exposures were, but usually they're going to be some sort of leukemia, lymphoma. So again, those have similar types of etiologies. Reproductive type cancers. So if we're seeing breast and prostate cancers, then those again have similar types of etiologies. It's when we're getting all over the place with lots of different body systems where we're not seeing similar types of etiology. So it doesn't mean that we have to have every single person reporting a leukemia, but we want to have some sort of cohesiveness with the etiologies that we're looking at. So the exposure that we're talking about, is it well defined? Was it high and prolonged? Was it chronic? Was it low level? And does the timing make sense? So if we're saying, if people are coming to us and said, you know, this chemical company just started to burn stuff 6 months ago, and we have 10 people in our neighborhood now that have lung cancer. The timing doesn't make sense there. Okay, and so, you know, while that you may end up with 50 people with lung cancer 40 years down the road from that particular company, it's not linked to what's going on now. So thinking about the timing of the exposures and how well defined those particular exposures are. Okay, the other thing you want to think about is the type of cancer unusual. So we might not have a large number of cancers, but if you're seeing a very unusual cancer, that can be a trigger that there's something to look at. The common occupational example we use is the angiosarcoma with the vinyl chloride. Angiosarcoma is extremely, extremely rare. You almost never see that type of cancer. So when 2 cases of that popped up in one particular manufacturing plant, that made the occupational physician sit up and take notice and say, oh, I never saw that cancer in my 30 years on the job, and all of a sudden I see 2. And so seeing a cancer that's extremely rare start to pop up can also be a clue. Is it an unusual age of onset? So are we seeing lots of, for example, very early breast cancers? So could there be something in the environment that's leading to a a huge increase in premenopausal breast cancers, because that's one of the things that's really hard to see is when we're looking at cancers that are more common, so sort of our big five like breast, lung, prostate, colorectal, when we're looking at those, it's really hard to see if there's some sort of environmental influence. And so one of the ways we can look is, are we seeing onset of those cancers at a much earlier age than what we would expect? So in much younger people, that can give us a trigger that maybe there's something going on. And lastly, what sometimes happens is that we can confirm a cluster. So there's a cluster of cancer cases here, but we can't link it to anything definitive in the environment because maybe there's really nothing defined that we can actually put it to. And so that's why it's really important to be able to have some sort of defined environmental exposure. Sometimes the public health workers will say, you know, listen, we can confirm that, you know, there are statistically higher number of cancer cases, but they don't hang together with what you would expect or the environmental contaminant that you're complaining about. They don't make sense with that type of, and we don't know what the actual environmental exposure was that caused it. And so that's where some of the difficulties come into play as well. The other thing is you have to think about the population. And again, this is where transience of the population comes into account. And what your baseline is for looking at your rates. One example is that there was thought to be a cancer cluster, I think it was in Marin County in California at one point. And they confirmed a statistically higher than normal rate of cancer in this particular area. When they went back and looked at it, what they found was that the baseline denominator that they were using to calculate the rates was not really reflective of the population that was living in the county now, because there had been so much mobility in that county that we had a much different population of women living there than what we were basing the rates for the denominator on. So again, thinking about, has the population in the area changed dramatically in a small amount of time, so that if we're using, for example, 2010 census rates and the population of the particular area has changed dramatically in the past 5 years, then using that 2010 population might not be a good base with which to calculate our rates.
What's the most common demographic shift that would lead to that situation?
So in this particular situation, what had happened is lots of affluent white women had moved into the neighborhood, and so there was a large shift, and breast cancer is much more common in older affluent white populations of women. And so that's what happened. The neighborhood kind of became, so if you'll see certain areas where they may have been demographically one type of group, and then the area then becomes the hot area to move to, and you'll see a big demographic shift. People are buying up lots of areas in a particular neighborhood in DC, and you see a lot of gentrification. Very quickly, your population base shifts, and if you're trying to calculate rates based on something that was 5 years old, your population may look very different. Okay, so that's all I have. We have 10 minutes, and so I was wanting to leave it open if you have questions or anything you wanted more information on. There's all of my information. Yes.
So has there ever been any link between, I've gotten this question before, I don't know how to answer it, but has there ever been any link between children in certain populations or children in certain neighborhoods who have asthma that eventually develop lung cancer? And that's a crazy question, but it has been asked to me, so I have to pose it. Does it sound that crazy?
It's really not that crazy. And the answer is that there's not a lot of research out there yet. Number one, I think because identification of large segments of pediatric populations with asthma is a relatively recent thing. And so, again, they haven't been followed through. And it's not a crazy question, but there's just not a lot of evidence. And there is some evidence that people who have previous respiratory disease do have increased risks for cancer, particularly respiratory cancers. But again, it's not known if that's environmental exposure, if it's something about their genetics and the way that their body clears respiratory toxicants. It's, is it environment, so that they're, living in an environment where they have lots of exposure to other things like environmental tobacco smoke and those kinds of things, pet dander, other sorts of asthma triggers. And so it's really difficult, and there's not a lot of studies. So yeah, unfortunately, there's not a good answer.
A few years ago, I covered the Joplin tornado, and at the time, and we didn't ever really report on this, but it always is kind of stuck in the back of my mind. At the time, there was obviously a ton of, earth moved, a lot of particulates in the air, and a lot of people got kind of respiratory illness in the months afterward, that the doctors didn't really know what was going on there. But it's also a heavy mining area, lots of lead and zinc in the area. People swim in mines for fun, apparently. But I've always kind of wondered, with the particulates in the air and one-time exposure like that, or over just a couple of weeks or months, would that ever have like a long-term effect, or is that something that would have to be almost constant exposure?
It doesn't necessarily have to be constant exposure, and again, it would depend on what was there. If it was something that wasn't going to clear. Like heavy metals, for example, they don't always have good clearance from the respiratory tracts, and so they could sit there and fester. And you think of things like silica, and so silicosis, and then it leads to cancer. Asbestos fibers, they don't clear well, and so again, there's a possibility that a very concentrated acute exposure could end up with lung cancer, just the same way you don't necessarily have to have a chronic long-term exposure.
It would be fascinating, though, to check around at the universities around there and see, is anybody studying it?
Yeah, I mean, that would be a population that you could follow and look at, because we know, okay, we had a one-time exposure, let's follow them through.
Is there a concern that we're overblowing this in our reporting, given the fact that, you're talking about percentages of 1 to 5% when you're looking, and also these are causal studies. These aren't cause and effect. It's a causal link.
Right. So have they not had they didn't have the lecture yet? Oh, okay. So you'll get a lecture later, and I won't steal whoever's thunder is going to do the lecture, looking at risk measures. And so, yes, there is a concern that, we see they'll talk to you about relative risk and attributable risk. Let me just go back, because this will be it. Okay. So here, this is looking at just an example from occupational studies. What I have is the population attributable risk. And what this tells you is in a population that's been exposed, what percentage of these particular cancers can be attributed to these exposures. Okay, so if we look at asbestos, the relative risk for asbestos and lung cancer is huge. But when you're looking at the population attributable risk, it's pretty small. We're looking at about a 6 to 13% of lung cancers in the population can be attributed to those types of exposures. So yes, you don't just want to think about what's the relative risk, but you want to think about what percentage of the population is exposed, and two, what your baseline risk is for that cancer. So if it's a very rare cancer and we increase the risk by threefold, we still only have a very, very small percentage of the population that's going to be affected by it. Now, it's not good to increase risk of cancer by threefold, but when we're thinking about how you're reporting about it, it's worth noting that even though the relative risk is increased, the impact on the population is not necessarily huge.
I thought you said earlier, but I probably misheard, that 70% of, well, you had 70% asbestos and lung cancer in a sentence.
It was with mesothelioma as well. So okay. It's mesothelioma, and yes, it's the link with lung cancer is much smaller than it is. It's much more specific to mesothelioma.
This is definitely not my area, but can we say anything about phthalates? What's the thinking about the risk of those?
Yeah, the jury's still out, and they're fighting.
Manufacturers, you mean?
Manufacturers, there's not a lot of agreement in the scientific community as well, as to exactly what there's not a lot of definitive studies.
Well, also, isn't there a lot of fighting about how to measure them?
Yeah.
Right? You know, some people are saying blood, some people are saying urine.
Yeah. And so that's one of the things where they don't even really know how to measure what your exposures are very well. What's the best way to measure it?
So, my sense is that most of what we're worried about, not such a big deal. Where is the big deal? What should we be paying attention to?
I don't know that that's entirely accurate. I think more of the message is that it's a big deal, but it needs to be reported cautiously, and not with, and I'm not saying any of you have done it, but I'm sure you've seen it, at least the sensationalistic headlines about, every day something new causes cancer. And so really thinking about the difference between a causation and an association, because a lot of these studies that we're seeing are observational. So they're an association, and thinking about, is it really causation? And it's important if we see an association, and it's something that we want to keep looking at. And do we want to, if we see a 5 times increased risk of something, well, do we want to keep exposing people to that? Probably not. And it's worthwhile to have that discussion, but it's not worthwhile to alarm the entire population about something like that either. So really thinking about a risk, kind of a risk assessment.
Well, and two, it looked like the environmental risk factors that did seem to make a difference were diet, smoking, viruses,
Yeah.
2/3 of cancer cases come from environmental factors, right?
Right, but environmental is sort of external.
We're talking diet and everything else.
We're talking diet, we're talking, yes, so really the big stories are things that people can control. Diet, exercise, smoking.
Sun exposure.
Sun exposure, yeah. Sun exposure is a huge one. Yeah,
Right.
viruses.
That's not going to cause cancer, but just saying.
Don't start that, Linda.
This is how ugly rumors get started.
That's autism.
So they got you on the record with that one.
To diet. I speak with a lot of researchers who have made their life into researching diet, and a lot of them are sort of changing their tune in terms of how much diet, and I'm not talking about anything that's on them, but like in terms of vegetables and that kind of thing, and how much that really would reduce your risk of getting cancer. And I was wondering if you could talk to that a little bit in terms of the scientific evidence. For this column, we have to basically include a couple of studies, and we find that the information is so conflicting that we can find a benefit in one study and no benefit in the next, particularly with recurrence rates, with like breast cancer, for example.
Do you have a nutrition person coming? Or no?
No, not specifically.
Oh, okay. So I didn't want to step on anybody's toes. Okay. And this is not my area, but what you'll find is that nutrition, if you think assessing environmental exposures are complex, assessing nutritional exposures are much more complex. And so I think that's why the studies are all over the place. It's just really hard to assess the impact of what people are eating. Number one, because people's diets are so changeable, and you have so many different patterns that you're looking at over a lifetime. And so when you're looking at chronic diseases, unless it's something that we're seeing a definitive link with, you eat too much fat, then you're going to clog your arteries. Okay, that makes some, we can actually see that happening. But I think with a lot of things with the carcinogens, it's just really difficult. One time beta carotene is good for you, and the next time too much beta carotene is going to give you cancer. I mean, it's you're all over the place, and so it's really difficult to evaluate that body of evidence. Unfortunately, I don't have a great answer to tell you other than it's conflicting.
Right. And how we tackle it.
Yeah.
Words of pure, just to try to make it succinctly make sense and actually be responsible to the reader's words, and it always ends the
Yeah, it's really difficult for consumers of health journalism to try to figure out what they should be doing based on, there's a new study all the time that's saying what's good for you and what's bad, and from week to week they can be completely different and conflicting, and that's just the nature of the observational research. Unfortunately, we can't put people in a clinical trial and force them to eat this diet for the rest of their lives and study, oh, okay, this diet works perfectly.
Right. We find too that after a lot of people have had cancer, some, not all, they'll take extreme
changes to their diets. Yeah.
Different things, and so when we publish this stuff, we have to sort of balance it.
Yeah.
It's a difficult 300-word column. Maybe hard to do in the features.
Is there anybody who has a question who has not yet asked one? Because I've got time for one more. Okay, Kelsey?
Okay. There's a place in Wichita called the Reardon Clinic, and they've been doing this stuff since the 70s, trying to say, like, vitamin C will cure your cancer, and I don't know if you guys have heard these things.
Mm-hmm.
It's really difficult for us to know, for me to know how to report on them, because they do their own studies, and, like, they have their own scientists, and they're all about natural medicine, and they, they're basically like, oh, you should do these IV infusions of vitamin C. I don't really know how to tackle that, and I'm skeptical because they're doing their own research.
Yeah, so I think it would be with a healthy dose of skepticism. I mean, really, the research that you want to get, and not that they're like completely making up things, but the research isn't peer reviewed. And so the research that you want to give the most weight to are things that are peer reviewed, that appear in journal articles. The other thing that I would caution you on is oftentimes there'll be scientific conferences, and so someone makes a presentation at a conference, and that's been peer reviewed. People look at it to decide whether this person should be allowed to present at a conference, but oftentimes what people are presenting at the conference are their preliminary results. And so then you'll see in the newspaper the next day, at the American Heart Association, so-and-so made a presentation that, this was the best thing to cure heart disease ever. And then there'll be a journal article, 6 months later that's not quite that enthusiastic. And that's because by the time you get to the journal article stage, you've gone through a lot of peer review. And so what I would say is that to put the most weight of evidence in the peer-reviewed journal articles, because that's where it's gone through the most level of review. Other scientists that are unrelated to the primary scientists have looked at that, and so it's had an unbiased review.
Great. Heather, thank you so much. This was great. We're going to present you with not the NPF mug, but the